Welcome back to the Oluck Health podcast, where we explore the intersection of science and care. I'm Hank, your host.
And I'm Eleanor. Great to be here, Hank.
Today, we're diving into a fascinating and incredibly important topic: why exercise, despite all the evidence supporting it, isn't routinely integrated into cancer care.
That's right. There's been a real paradigm shift over the past decades. We now know that exercise has therapeutic benefits for people living with and beyond cancer, but translating that evidence into routine oncology care has proven surprisingly difficult.
And that's exactly what today's episode is about. We'll be unpacking the barriers identified in a comprehensive scoping review by Kennedy and colleagues published in 2022. They used an ecological framework to classify the barriers at 6 different levels of the healthcare system.
And to make it even more relatable, we'll illustrate these barriers using fictional client scenarios based on common themes seen in Australian healthcare. We'll also highlight some exercise physiology perspectives, drawing from Exercise and Sports Science Australia, or ESSA, guidelines.
Before we jump in, a quick disclaimer.
The information shared in this podcast is intended for educational and general informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. Always consult with a qualified healthcare provider before beginning any exercise program or implementing any health-related strategies discussed in this podcast, especially if you have a chronic medical condition or existing injury. Do not attempt to apply any techniques or interventions mentioned without appropriate professional guidance and supervision.
So, Eleanor, can you start us off with an overview of the 6 levels of barriers?
Absolutely. The ecological framework used in the review identifies barriers at the following levels: innovation, individual professional, patient, social context, organizational context, and economic or political context. These levels interact, and sometimes a single issue spans multiple domains.
Let's begin at the innovation level. That sounds a bit abstract. What does that actually mean?
Great question. Innovation-level barriers relate to the characteristics of exercise interventions themselves. So things like how feasible or credible the intervention appears to the users.
So it's about how exercise programs are perceived by health professionals or institutions.
Exactly. One common concern is feasibility. For example, the belief that exercise is too hard to implement during active treatment due to fatigue or immune suppression. There's also a lack of standardized protocols across treatment types, making it hard for clinicians to know what to recommend.
That reminds me of a fictional client case. Let's say Robin, a 58-year-old undergoing chemotherapy for breast cancer, is told by her oncologist that exercise could help, but the oncologist doesn't specify what kind of exercise, how much, or when to start. So Robin feels unsure and decides not to act on the suggestion.
That's a classic example. The innovation isn't packaged in a way that makes it easy to adopt. For exercise physiologists, this is where ESSA guidelines become crucial. They offer protocols tailored to specific cancer types and treatment phases, but those protocols aren't always communicated clearly across healthcare teams.
Next up, individual professional level barriers. This one hits close to home for many clinicians.
It does. These barriers relate to clinicians' knowledge, attitudes, and behaviors. Many healthcare providers report low confidence in their ability to recommend or prescribe exercise. They may lack training in exercise oncology or be unsure how to refer appropriately.
And sometimes they may hold outdated views. The review mentioned that some providers still perceive rest as the safer option during treatment.
Exactly. Or they may assume patients wouldn't be interested. For example, a GP might think an older patient like 75-year-old George, recently diagnosed with prostate cancer, wouldn't benefit or want to engage in physical activity. So they don't bring it up at all.
Which brings us to the patient-level barriers. What's stopping people with cancer from taking up exercise?
There's a range of factors. Patients may lack awareness of the benefits, feel uncertain about safety, or believe they're too fatigued or unwell to participate. Some might have mobility issues or comorbidities that complicate things.
I imagine fear plays a big role too.
Absolutely. Think of fictional client Layla, who just finished radiation for cervical cancer. She wants to regain strength, but she's afraid that exercising might cause pain or setbacks. And if no one guides her, she'll likely avoid it.
These fears make sense, especially without support. And that takes us to the next level, social context.
Right. This level considers the influence of colleagues, workplace culture, and interprofessional collaboration. A common barrier is lack of leadership or a culture that devalues exercise in cancer care.
So even if an individual nurse or oncologist supports exercise, they might not speak up if it's not part of the clinic's broader culture.
Exactly. And without champions to lead the charge, change is slow. For instance, if allied health professionals, like exercise physiologists, aren't integrated into oncology teams, their expertise goes untapped.
That really ties into the next level, organizational context. This one had the most barriers in the Kennedy Review, didn't it?
It did. Nearly 40% of the identified barriers were organizational. These include lack of staff, limited time in clinical appointments, no dedicated funding, and no structured pathways for referrals to exercise services.
Let's paint a picture. Say you're an oncologist at a busy public hospital in Melbourne. You've got back-to-back patients, limited admin support, and no in-house exercise clinic. Even if you want to refer someone like Ahmed, a 62-year-old colorectal cancer patient, to an EP, you don't know where to send him, so it just doesn't happen.
Exactly. And even if an external program exists, the disconnect between services makes referrals patchy. A nurse once said, "You don't plant the seed unless you can water it." Without infrastructure, discussions about exercise are abandoned.
Lastly, let's talk about the economic and political context. This is the big picture stuff, right?
Yes, it includes healthcare policy, funding models, and regulations. For example, in Australia, Medicare may not adequately cover exercise services for oncology patients. This makes it hard for private practices to provide affordable care.
And public hospitals often can't employ exercise physiologists full-time. So even if a service is set up, it's underfunded or short-staffed.
Correct. One solution could be embedding EPs into multidisciplinary teams funded as essential staff, but that requires a shift in policy and investment.
So, to recap, barriers exist at every level, from how exercise is presented and understood, to who's promoting it, to whether systems and policies support it.
It's a complex picture, but understanding these barriers helps us start building solutions, and the ecological framework gives us a roadmap.
Absolutely. Before we wrap up, what can our listeners take away from this?
If you're a student, clinician, or just someone interested in health, know that promoting exercise in oncology isn't just about the science. It's about systems, people, attitudes, and leadership. We need all of those aligned to make exercise a routine part of cancer care.
And if you're a patient or caregiver, don't be afraid to ask about exercise. It's not just safe in many cases, it's beneficial. But make sure you're getting guidance from a qualified exercise physiologist.
Well said. And we hope today's conversation made this topic a little clearer.
Thanks for tuning in to Oluck Health. Don't forget to subscribe, and we'll see you next time.
Bye for now.